Okay, please go ahead.
Is Dr.
Nisha Yadav, last paper, sir.
Okay.
Keynote address, sir. Okay.
Good afternoon, all.
This is non-competitive.
This was a study done to compare active dichoptic therapy versus part-time occlusion in cases of anisometropic amblyopia. There are no conflict of interest to declare on these slides. Binocular perceptual learning approaches, often referred to as binocular or dichoptic treatment, it involves splitting of visual stimulus elements between both the eyes. Dichoptic games give binocular stimulation that rebalances the contrast between the two eyes, where the amblyopic eye elements are presented at a higher contrast and the non-amblyopic eye elements at a lower contrast to overcome intraocular suppression and enable simultaneous perception. This further improves visual acuity and sometimes binocularity and stereo acuity. This was a prospective randomized interventional study done at Dr. Rajendra Prasad Center for Ophthalmic Science, AIIMS, to compare the visual outcome of artificial intelligence integrated active dichoptic therapy versus a standard monocular treatment approach, that is occlusion. Patients willing for this study were included in the study, which involved patients between the age group of 5 to 16 years, mild to moderate cases of anisometropic amblyopia, and who had ready availability of laptop, tablet at home for daily access, and those who were treatment naive except for the use of spectacles. After the patients were selected, randomization was done. After the patients included, randomization was done and two groups were created. The first group received dichoptic therapy for 1 hour per day for 6 months, and the second group received occlusion therapy for 2 to 6 hours per day for 6 months. Follow-up was done at 6 weeks, 3 months and 6 months to assess for best corrected visual acuity for distance and near, binocularity using Pagolin's striated glasses, contrast fusion using Pelly-Robson chart, stereo acuity both distant and near, and the secondary aim of the study was to check the compliance in both the groups. We concluded at the end of 6 months that the age and demographic profile in both the groups were comparable. The best corrected visual acuity in both the groups improved from baseline to 6 months after the end of the intervention, although it was statistically non-significant when compared between both the groups. The near vision also improved in both the groups from baseline with p-value 0.2 to 6 months, although intergroup p-value was not significant. The contrast sensitivity, as you can see in the dichoptic group, it improved from 1.3 to 1.6, which with a significant p-value, and in the occlusion group also it improved with a significant p-value, but between both the groups it was better in the dichoptic group at the end of 6 months. Coming to the binocularity, which was tested using Pagolin's test. Initially, when we started at baseline, it was almost 13.33% of patients with binocular vision in the dichoptic group, which improved to almost 100% at the end of 6 months. Whereas in the occlusion group, we started with 10% of patients and it landed up to 80% gaining binocularity at the end of 6 months. And it was definitely better in the dichoptic group at the end of 6 months. Distance stereo acuity and near stereo acuity both improved in both the groups, but intergroup it was better in the dichoptic group with a p-value significant, as you can all see in the graphs. The secondary aim of the study was to see the compliance between both the groups, and we concluded that out of the 30 children in both the groups, 28 out of 30 in the dichoptic group were compliant for playing the video game, which was assessed by monitoring their scoreboard and seeing their online progress periodically. As you can see in the picture, we just used to log in with their credentials and we used to have a look at how the child is performing. This dark blue boxes represent that the child is doing the exercise for 1 hour per day continuously every day, and whenever it is a blank or whenever it is a light color, that means the exercises has not been done properly, and we used to enforce the compliance by calling the patient, by enforcing compliance through parents. Whereas 22 out of 30 children in the occlusion group were compliant for patching, which was assessed by asking questions to parents and observation at home. Compliance was reinforced again in the patching group by regular parental counseling and motivation. To conclude, the best corrected visual acuity and near vision improved with both the interventions and was comparable at the end of 6 months. Stereo acuity, contrast sensitivity and binocularity were all improved in both interventions. However, statistically significantly better improvement was seen with dichoptic therapy at the end of 6 months. The secondary aim of compliance was better in the dichoptic group due to regular monitoring of the scoreboard and more engaging games which enrolled the children further to do it, and regular enforcement of compliance is required in both the groups. Hence, dichoptic therapy is a good alternative in terms of binocular vision and quality of vision. Thank you.
So excellent study this. So now coming to the, if we talk about vision as a wholesome phenomena, so it's beyond the logmar and the Snellens. I hope you agree with me. So now coming to the shape perception, the contour, the hyperacuity. So by any means you could have compared those things in these two groups?
So the contrast sensitivity was definitely compared, but as you said, the hyperacuity was not compared.
Okay.
Whether the child was able to perceive more sharp images after the intervention ended.
Thank you. Yeah.
Does the type of amblyopia affect the results?
Yes, yes. As we have done a review of literature when we initially started this, so many previous studies have been done in past, which since this was only including the anisometropic amblyopia and that to mild to moderate cases, we had landed up with a good result. But since all the previous studies involved heterozygous group of patients, both involving mixed amblyopia, strabismic and anisometropic, though those resulted, the results were not as good as we have received.
So any difference between the myopic amblyopia versus the hypermetropic amblyopia? Means does it improve more rapidly in the myopic amblyopia groups?
Sir, to be very frank, we got many patients when compared were myopic rather than hyperopic. So definitely at the end of 6 months, we saw that the myopic patients were improving greatly, mild to moderate cases.
And does these strabismic amblyopic patient, the degree of squint, does it decreases after the therapy little bit?
So we excluded those. It was not a heterozygous.
No, I'm asking about your experience. Forget about this study.
Sir, if it is yes, I have seen like after the study was over, we started giving it on a regular basis at our center. So if it was a mild grade of strabismus, so it definitely improved in the
Yes, it improves.
Yeah, in the initial stages, in the growing age of the child.
Thank
So
you.
what instrument did you use for dichoptic therapy?
Sir, it was a software, artificial intelligence based software named QRC.
So the child would practice at home daily?
Sorry?
The child would practice at home
Yeah,
daily?
it was an online software which was initially the child was called first, the parents and the child was explained about it and regular follow-ups was done. They could do it sitting at home comfortably. They did not come to the center every time.
So in cases with mixed amblyopia with strabismus also, did you recommend this therapy after aligning the eyes? Or they were also excluded? So with mixed amblyopia, I mean with children with having squint also, is it useful for therapy after the squint is corrected?
Sir, after the squint surgery, sir,
Yeah.
not done many cases, not enrolled. But like before surgery, if it was a mild grade of squint, like maybe 15 degree of exo or ESO, so those children definitely improved.
Okay.